Everyone. Once again, very happy seeing you. And also for those online. So for those of you last time know me, I'm President, the director for Smart Aging. Okay, so some weeks ago, we have delivered 3 lectures by 3 experts in the area. And I have conducted an over introduction of innovation and technology in this area. So later on today, I will come back. Okay, around 8 o'clock, I will come back. But before that, okay, I'm very happy that we have 2 other speakers, two experts. One is Professor Xiaoling Hu, already here. So she will discuss first about the rehabilitation using some innovation, okay, for stroke rehabilitation. And later on, we have another expert from President who is from Department of Environmental Engineering. And there's another colleague, Professor Yiling Kwang, from the Language Science and Department. She is a speech therapist to talk about the problem of aging, the swallowing, okay, the eating. So that is another big issue in elderly care. So she will discuss some new technology in this area as well. Then later on, I'll come back to discuss some technology about ultrasound for different applications, particularly brain and muscle. So I will come back later. So I'll pass to Professor Xiaoling Hu first. Yeah, so Xiaoling.
Thank you.
Yeah, let's welcome.
Good evening, everybody. Thank you for attending the lecture. And I will host the first lecture. I would like to introduce to you about our new inventions. It's mainly related to the robots that designed for stroke rehabilitation and which facilitate the stroke patient can practice in their home environments and also facilitate the professionals. They can handle multiple patients remotely and to improve their working efficiency. So the title of my presentation is Mobile Exoneuromusculoskeleton for Personalized Telerehabilitation Post-Stroke. So I would like to know how many of you, the online, I think possibly I just mainly take care of the on-site part. Okay, so how many of you noticed what's the main difficulties for the persons after stroke? Do you know what is a stroke and what is the consequence of stroke? And stroke actually has been identified as the leading cause of adult disability worldwide. Okay, and in China, because of the fast aging of the societies and the accumulated stroke survivors has reached to 40 million by 2024. And because of the improvement of the rescue medical technologies, the survival rate has significantly improved. However, the people after stroke, when saved the life, usually experience severe impairments in their body, particularly the half body paralyzed, we call it hemiplegia. And in Hong Kong, it is also because due to the aging of the society and the prevalence of the stroke annually is also increasing, actually doubled. It has been doubled during the past 10 years, around over 50,000 of new stroke cases have an area in Hong Kong. And however, because of the limited public health supporting system of the society, majority of the stroke survivors only can stay shortly in the hospital. In Hong Kong, usually it's only 3 to 4 weeks hospital stay, then to be discharged to home. And after the discharged in Hong Kong, the patient only can access the day hospital service within the first year after the onset. And after the first year, definitely they are still paralyzed. Then mainly depend on the private clinical rehabilitation market, but not all of them can afford this kind of long-term charge. The situation in mainland China is much severe than in Hong Kong. Majority of the stroke survivors, most of them lack of the long-term support, not only for the difficulties or challenges faced by the discharged patient, even in hospital, after we go went over the pandemic. We know the pandemic, in order to control the in-hospital infection. And usually the traditional practice, for example, to gather a group of patients to rehab in the common treatment room. This kind of situation actually is forbidden, is prohibited or constrained in the pandemic, during the pandemic. And they have to be limited in the ward. And however, are we ready, prepare for the next pandemic? So it is still a question mark. So we need to solve this kind of problems. Keep increasing of the stroke populations because the insufficient professional manpower support in the industry, and also how to control the infection during the in-hospital, and also during the face-to-face practice, physical training in the day hospitals is a big problem. And therefore, we would like to explore any chance and what is the ideal situation for to provide a qualified long-term rehabilitation service for the stroke survivors. Actually, we hope that the automation or the technology can help us. And for example, we can ensure that kind of technology is effective in rehabilitation. That is the first priority, right? And then it's easy to use by non-professionals when professionals are forbidden to get close to you. For example, during the pandemic we experienced, most of the outpatients service has been stopped or suspended. And also we hope that the technology can just give the precise rehabilitation to personalized needs. We call it personalized management or rehabilitation progress. For example, some of them possibly this treatment is suitable for patient A, but how long it will be given, and after the period, whether we need to change to another treatment. So this kind of incremental or progressive adjustment in the long-term service should be taken care in the personalized management or rehabilitative progress. And also, when the patient and the professional are separated remotely, then any technology can reconnect them together for the effective communication in the long-term service. So it is another needs we desire for. In the ideal future service in the automation in long-term rehabilitation management. So we hope that the rehabilitation could be accessed and is available anywhere, anytime for anyone. And how to do that? Because I'm engineering background. Therefore, as a BME engineer, so actually we have working with together of the engineer expertise, and we design robots. Rehabilitative robots is not a new term. It started in the last century. And when the booming, the aging of the society, and also the booming of the robot technologies, and a batch of the generation of the robots has been designed. In early days, you will find that it usually is large robots. And these kind of robots has been helped release the labor works of human therapists, okay, and support them a lot. And also with increasing the improvement of the control algorithm, the robots become smarter and smarter and lighter and lighter. You will find that we just pick up some of the representative robotic systems in the development history, and also we proudly to present the robots that designed homemade by BME PolyU, which has been tagged with the logo of PolyU. All of the robots are designed by BME PolyU, and starting from the 2009, we developed the PolyU bot. It is a huge robot. It is a large equipment. Okay, cost a lot. Okay, but it is our first smart robot that can provide the treatment intervention to the upper limb and the lower limb. And but based on that, and our robots has been evolved together with whole robot histories that become. First, we adopted the exoskeleton for the robotic hand. And we call this is a hand robots we designed in 2010. Okay, and then based on that, we gradually, okay, improve the multi-module assistance in the robotic design. For example, you will find that, okay, yeah, these are the robots, multi-robots that take care of the exoskeletons and for the upper limb, for the elbow, wrist, and joints, together with targeted muscle stimulation, this combination can help the patient to restore the motor function much faster than the pure robot support. So that is our early hybrid robots. And with the emergence of the soft robots. Okay, soft robots, possibly you heard you have heard a lot about this, right? And it is because soft with a good interaction with the human bodies and also can provide the good support to the joints. And therefore we integrate the soft robots and other sensory stimulations into the combined design. And then we come up with the latest upper limb and the lower limb design for stroke. Because of this compact and lightweight design, and we make this whole device become the IoT, the Internet of Things medical device, which facilitates the patients can do it, okay, in indoor area and in outdoor area, and also even during the mobile, okay, is in a mobile system. That means, okay, the patient during the exercise under the sunshine, they can do it. And remotely, we use the IoT technology, help the professionals can remotely monitor, okay, how is the compliance of this kind of device used when the patient is at home or just outside the clinical environments. So today, I will mainly introduce our latest invention that is called the exoneuromuscular skeleton for the upper limb, this one, okay, and also the lower limb, the ankle foot. And our upper limb systems has been commercialized, is a product in Hong Kong and adopted in a lot clinical institutes in Hong Kong. And now we are promoting the market in China, mainland China. Okay, so our upper limb and the lower limb systems looks like that. Okay, it looks like the sportswear, So why we adopt this kind of design as outlook is very important. It is because when we did, okay, we conducted the large robot clinical trials. Most of the stroke persons, the persons after stroke, just complained. Okay, I said, I don't want to be bonded in a fixed place. For example, in the hospital or in the clinic, I don't want to be tagged as a patient. Okay, the desire of my participants in the clinical trial said, I just hope that wearing this kind of device, just doing the exercise in the park, okay, I want to be regarded as a healthy person. When I received the rehabilitation training, as if I'm doing exercise in the park. So actually, this is a desire from the patient, and also they don't like the exoskeleton, the transformer look. Okay, it is because they just feel disordered. It is because if you were wearing something out in the public, okay, don't want to be so eye-catching. Therefore, we try to we just packaging all the mechanical and electronic mechatronic components just wrapped over with sports design, so they like it. This is our upper limb. Okay, upper limb. No, wait. Okay, and although the outlook it looks simple, but actually inside it integrated the high tech. Okay, and we integrate what? Okay, first is exoskeleton, the skeleton elements, and then we combine it with the soft pneumatic muscles. Okay, and which can actively provide the mechanical support to paralyze the joints and to do the designed movements, for example, extension or flexion. Sorry. And then we also integrated the the stimulation, okay, the electrostimulation targeted to the paralyzed muscle, okay, and we will teach each paralyzed muscle when and how to contract in a coordinated motion. And then besides the electrostimulation, we also integrate the tactile stimulation, that is a vibration, okay. And later I will introduce why we integrate these two different types. It is related to the rehabilitation theory and to try to help the patient to can reconnect the broken nerves due to the stroke, okay. So and beside that, okay, and we also try to help the non-professionals can operate the system easily or independently without the help of the professional like the doctor or the engineer beside him. And therefore we designed the app interview, the interface by just press one button, okay, then the device can work already, just like the iPhone with one button, okay. We just use a very simple app interface, okay, just one button, then can do it, okay. Of course, we before the usage, the professionals will set the parameters for a specific individual. But after setting, the patient can just use a mobile phone and with the device turn on, press, then do it. So that is our design. And for the upper limb, yeah, would you please play the video? And this is a video. Yeah, okay. This is This video shows the working principle of our upper limb system. Actually, we just use the electrodes to detect the paralyzed muscles residual signal. We call this EMG. And by using this residual EMG, we can drive the system to provide the additional support, either the mechanical or the targeted stimulation to this muscle, and to help the patient complete the designed the limb movements. For example, the elbow extension, elbow flexion, and with the hand extension, with hand flexion. And so that during this coordinated movement, the patient can practice the daily tasks like the forward rotation, withdraw, or lateral rotation, up and word. Okay, just doing this repeated practice. And then since the device is quite small and light in weight, and the mounted part is only less than 100 gram, so it is easily will not cause additional loads to the paralyzed limb, and they can easily to practice with the support of the device, comparing to the large systems. For example, exoskeleton usually at least, okay, it will weigh more than 1 kg, larger than 1 kg, okay. Then by using this device and also a small control box weighted around 500 gram, okay, and then they can take this device with the mobile phone and to practice in their living room or go out to the side in the park, sit down and practice. And the upper limb device is mainly try to correct the impairments. Okay, first is to practice the muscle force, and then is to correct the compensation movements. We also call it the discoordination in the muscle groups. And I would like to know how many of you have closely looked at the behavior of a stroke patient. Please raise your hand. Yeah, and actually for the stroke patient, you will notice that because of the reorganization in the impaired nerve pathways, and the patient usually will demonstrate a lot of compensation movement. For example, if we asked them to do the hand gestures or the wrist motions, you need to use the proximal muscles to compensate the movements. So this kind of compensation motions are mainly because of this coordination among the muscles in the upper limb. Okay, and usually the distal muscles is more impaired than the proximal. Therefore, you will always see the body trunk movement or the shoulder movement instead of the desired, the distal movement. And in our systems, the key merits for this design actually is we can revive the distal motions through the targeted stimulation. This kind of stimulation not only can tell the muscles when to contract, but also the stimulation will cause a sensory response. Okay, the sensory to the stimulation to the distal muscles, it can stimulate the ascending pathway, the nerve pathway from the distal muscle to our central nervous systems, and so that practice the distal muscles, and therefore it can correct. Okay, it is not only can improve the muscle force, but also can correct the discoordination among the upper limb muscles. Okay, so that is our upper limb. And then to 2023, okay, we completed the lower limb. The lower limb is mainly targeted for the correction of the ankle foot impairments. After the stroke, usually the patient will experience the foot job and foot inversion. Do you know what is a foot job? The foot job actually is the patient is unable to do the dorsal flexion. Okay, dorsal flexion of the foot during the swing phase, and then it's always just like drag the foot so that it's easy to cause a fall. And the foot inversion actually is during the when they're working. Okay, it is experienced imbalance in the frontal plane, and therefore it's just like outside. Okay, but usually the foot inversion and foot job coexisted in the post-stroke ankle foot, and however, it is still difficulty. It's difficult to correct them and to rebuild the voluntary efforts, the voluntary capability in the post-stroke foot. Therefore, if a person, the foot job, the ankle foot is impaired, what is the consequence? For example, if your leg is broken, what is your habits? What will happen in your daily life? You just sit there immobilized, right? Okay, you don't want to work. But this is a big problem for most of the stroke patients. It's because they dare not work. They just sit there immobilized. Then it will cause the whole deterioration of the body. The effect, the consequence is not only the leg, not only the foot, but the whole body's the exercise, the whole status will deteriorate very fast. And therefore, to help them to work and work normally and symmetrically, it is a challenge after stroke in the lower limb rehabilitation. Okay, and our design is like that. Would you please play the video? And therefore, we designed our small device. Okay, so this is our lower limb exoneuromuscular skeleton, and we integrate the pneumatic muscle for the force support to the ankle joint, and also we use the three pressure sensor at the plantar to detect the gait events, and then we give the ankle foot dynamic support in different gait events during the working. For example, when it is in the stem phase, then we put our body weight, okay, in the leg, then our pneumatic muscles will inflate it and hold the ankle joints and let the patient dare to move their body weights to the impaired limbs, okay, and so that it can strengthen the muscle in this leg. And during the probation phase, okay, and we will give the electrical stimulation to the GA muscle. The GA muscle will help the patient to generate the probation. And usually the patient, the lack of this phase, they just throw their leg, okay, throw their leg in the just put. put the whole head, the leg, and let the planter just contact the ground immediately. And also during the swing phase, we give the stimulation to the TA muscle. And once we stimulate the TA muscle, then it can during the swing, okay, stimulation is muscle, and the foot can do the dorsiflexion. So we correct, okay, we can correct the foot drop problem. So that is our two devices, okay, and for your interest, okay, possibly you will would like to understand. We just briefly introduce what's inside. The merits actually is quite complicated. If you just tear over its close cover, the packaging, and actually why it is new is because we integrate the pneumatic muscle and the exoskeleton in one piece. Possibly you heard about the exoskeleton, right? It is rigid. It's rigid, right? It's heavy. And pneumatic muscle, it is softer, right? And it's light. But the two has advantage and the disadvantage. Okay. And the disadvantage of the rigid is first is the hard, and it's not very skin friendly. But okay, it can provide quite good mechanical support. Okay. And for the pneumatic muscle, it is soft, but it in order to provide the mechanical, the torque support, the force support, you need to inflate. It's inflated with a pump. If the pneumatic muscle's volume is quite large, that means you take time to inflate it to a targeted force, right? So it will affect its response. And in order to make a good trade-off between the lightness and the hardness and also the response time, therefore, we optimize the two together. That I would like to thank the industry center. They did very good mechanical fabrication. They can integrate them together and to make it small in size, compact in size, and also still light in weight. And at the same time, we can just use a miniature air pump, as small as a blood pressure pump. Okay, we can use such a pump to inflate, achieve a very fast response. So that is our invention inside. And then we applied this muscular skeleton, called the muscular skeleton, integrated for the elbow and the finger. We applied the key joints, then come up with the mechanical support in our device. And then, okay, we asked our textile clothing department help us to design the sports outlook, and then just embedded all the mechanical and the electronic things into this small design. So just from the outlook, its appearance, it's simple, just like the wearing system. But inside actually is composed a lot, and also the control box has the 4-channel electrostimulation and the EMG channels that can simultaneously detect the different muscles residual EMG at the same time through the same pair of electrodes, give the stimulation to the target muscle. So that is the beauty of the miniature compact design in our system. And just now I just introduced the static or the hardware, how the hardware mechatronic platform designed for our robots. But actually, if we need to make it to be alive and to give the dynamic help of our paralyzed limbs, we also integrate the control, the rider control system that is integrated into a MCU, a very small chip. Okay, it can run in real time to handle the complicated multi-joint coordinated motions. Okay, so that is how is the EMG driven control logic flow inside. Although it looks at the small products, but inside actually contained a lot of things. But when we design this, I would like to share with you how we make it precise. Actually, after we design each piece of it, we need to quantitatively measure how much is the force it can provide during the support and in corresponding to different air pressure inside. So we need to do the quantified evaluation of each finger and of each joint, okay? And by using this, okay? And also we need to detect corresponding to what kind of pressure we inflated, then how much is the force it can be achieved, and how large is the joint angle it can support. So that is engineering work we need to do before we applied it to the stroke patient, to the clinical trial. And also we need to measure its dynamic response. That is, okay, using a certain power of the air pump and how fast it can react to the applied resistance. So we call it that is the pressure torque transmission and also the response time. And we find that our device, through the optimized combination of the mechanical systems and also pump power, we found that it's quite good. And comparing to its peer products, and possibly you don't like the numerical figures, but at the time of the designing, that is the best performance in the soft robots achieved comparing to all robots around the worldwide. Okay, so it is the fastest. It can provide use the lightest weight, but can provide the highest torque support with the fastest response with a miniature pump. So that is what we achieved engineering. And then, okay, we also need to apply our device to do the human experiment to make sure what kind of assisted combination, okay, can achieve the best supports to stroke patient. And therefore, we also recruit the stroke patient to attend this kind of experiment. You should remember that our device actually incorporated mechanical support and also the electrostimulation. And we would like to know what kind of combination and what kind of a percentage of the combination can achieve the best support. So the purpose of the experiment is like this, okay? And we find that, okay, once the electrostimulation and mechanical support combined together with 100%, that is, or they are so the full 100% support actually can achieve the best behavioral coordination in stroke patient with long-term impairments in the upper limb. And therefore, once we know this, okay, the optimized combination of the supports, okay, then we also measured the quantified, again, in each joints at the supports, how it behaves and how fast it can achieve. After we evaluated this, then we recruit the patient to see, okay, if we use this kind of device, give them 1 month to the repeated training, what will happen? Okay, that is related to our evaluation of the device design to see its rehabilitative effectiveness. And actually, here, this slide shows almost a conclusion. It is because we already know that if we turn on the electrostimulation to the parallel muscles, at the same time, provide the joint coordination with the external force, actually, it can achieve the best rehabilitation effects through our neurological evaluation. It has been found that as a stroke patient after stroke, okay, one of the reasons cause the compensation is the compensation is not only happen, is not originated at the muscle side. Mainly it is because due to its neuroplasticity in the cortical side, okay. And for the healthy person, usually, okay, our muscle movement is controlled by the contralateral neuron tract. That is our right hemisphere, our brain, control our left part of the body. And our left hemisphere controls the movement in our right side of the body, right? That is a healthy person. But after stroke, it changed. Okay, if there's a lesion due to the stroke, for example, it happened in the left hemisphere, then okay, after stroke, our brain can adapt itself to save our body, to reduce the impairments, the behavior impairments. But usually, okay, this kind of adaptation is random. It will cause, we call it the ipsilateral compensation. That is, it will happen, okay, because the left hemisphere injured, okay, then okay, our right side body paralyzed, right? But the residual movement, you will find that after, even without medication, without rehabilitation, some of the motor returns will come to the right side body, but it's mainly because the control, it is a control from the right hemisphere. But it has a problem. It just has a problem. And why? It's because if you use the right side hemisphere to control the right body, the majority projection of the neural nerve tracts is come to the proximal joints, less come to the distal joints. That's why, okay, stroke will result the severely impaired distal joint movements. It is because if you rely on the same side control, okay, this part of the muscles heavily rely on the contralateral nerve control is lost. Therefore, okay, the best rehabilitation is try to guide our stroke patient, okay, the neuron restoration with the center in the contralateral control rather than depends on the same side control. Okay, so we find that if we integrate the mechanical support and electrical stimulation through the sensory input, okay, actually we can revive this kind of contralateral in our nervous system. Therefore, after a period of training, people can rehab and have good performance, particularly with hand functions. So this kind is very important because the arm functions, majority function is performed by hand and wrist, right? If you can doing the shoulder and the elbow, but the hand cannot open or cannot move, you still cannot complete majority of the daily tasks. Therefore, in stroke rehabilitation, one of the challenges actually is to rehab, okay, restore the hand with the hand functions. Okay, so our device if we give the stimulation, electrical stimulation, together with the mechanical support, it can first is mainly contribute to the contralateral control and then revive the distal joint function. So after we know the mechanism, then we go one step further, is try to see, okay, without the professional support, where the patient can take our device home, okay, and do the rehabilitation at home by themselves. And the professional just remotely monitors the training performance. So actually with success, okay, we conducted the translational rehabilitation and in collaboration with the hospital authority, the community rehabilitation service support center. And one of the lucky things is that we're doing this kind of translation, telerehabilitation at home during the pandemic. Okay. And before the pandemic, actually no one interested in the telerehabilitation. They would like to, patient would like to receive the face-to-face close contact from the therapist. But during the pandemic, this kind of service suspended. And therefore, okay, they were quite welcome our device. And luckily, and they adopt our device, and we teach the PT and OT professionals in the center. They just give 3 tutorial sessions to the patient. Then the patient can take the device home and complete the rest of the 1 month training at home. Even the PT and professionals got infected of COVID, but the patient still can continue the training at home. Okay, there's no stop for them. And after we know that, okay, it is successful. It is all the patients recruited, they completed the training. And one of the very interesting observation is that we found that, okay, when the patient have the freedom to choose when to do the training every day, we just record the data. We found that majority of the patient or popular training time is mainly concentrated in 2 time slots. The first is in the afternoon, 2 p.m. to 4 p.m., and also in the evening, the 7 to 9. So you can imagine, okay, in the traditional the outpatient service, the time slots possibly is not the favorable time slot for patient. That's why the attendance may not high for the outpatient service. But if we have let the patient have the freedom to choose when to rehab, then the compliance can be improved. So that is our the story of our uplink. Okay, and then after the clinical trial, we established our own company, and also in the science park. Then we commercialized the uplink, and now it is being the products in market. And the lower link is on the way to the same way to the as the uplink. And also, we also received a lot of recognitions, including the invention awards. And more recently, in 2023, the uplink device has been awarded as excellent product by Chanlin. Yeah, so in China, so it has been the products. And currently, a lot of private clinical centers adopted the uplink. For example, the Finest, they purchased our devices and do the home the home visit service. But the service is not provided by nurse or healthcare providers. They are just the general workers, okay, with the training. Then that means, okay, there's not required that the professional, there must be a professional to do the training, and so that more patient can afford this kind of service through this kind of, based on this device. And currently we are doing the multi-center clinical trials in mainland China to explore the inward self-help rehabilitation during the early period, comparing to the larger robot in the big hospitals. So the study is still ongoing, and the feedbacks currently is quite good. And then let me talk about, we still have the time to talk about the lower limb. Our lower limb is try to correct the foot job and the foot inversion based on the understanding of the upper limb. Then it's easy for you to understand the lower limb device. So we try to correct the foot job and foot inversion, but traditionally, this problem is solved by this passive AFO. Okay, this kind of the orthotic devices, but this kind of device is cheaper and also quite widely adopted. It's very effective once you put on the foot job and the foot inversion immediately corrected. But the long-term usage of this passive AFO will cause muscle atrophy. It is because the patient will quite often rely on the mechanical support of this device. There's no chance for them to practice the voluntary muscle force at the ankle joint. Once take off, then it's very easy to cause a fallen or the broken. So, however, in the current lower limb markets, you will find all these kind of very popular, famous lower limb device. You will find that the design at their ankle joint is quite oversimplified. It's oversimplified, almost just like the passive or AFO. So it is one of the empty room that we tackled. We just targeted the problem of the distal lower limb joints. Although there are some unilateral soft robots, but still very bulky and very heavy. And majority of them only correct the foot job, but cannot at the same time to correct the foot inversion for the post-stroke ankle joints. Therefore, our device, let's see our device. Our device, just like that, is also coupled design with the same team members we gather together within PolyU, the IC, textile clothing, etc., and computing. And we just make the whole things very compact in size and very light in weight, just like that. And with a total weight less than 400 grams, including the battery. And once charged, if fully charged, it can support 4 hours continuous practice. And also we use, in this design, we not only give the stimulation, electro stimulation to the muscles, but also introduce vibro stimulation. Vibro stimulation just put in between the first and the large and the index toe. And once we find that the plantar imbalanced, that means it's outside, the foot inversion detected, we will give the vibro stimulation. Vibro stimulation. And this vibro stimulation, the patient can perceive very fast. It is later I will explain. And once they perceive this vibration, then they are required to put more body weights to the toe to correct the inversion. And by this repeated correction, the patient can gradually learn how to position their foot correctly during each step. And why we use the vibro stimulation to correct the foot imbalance? Foot imbalance is very easy to cause the asymmetry or fallen. And therefore, we need to find a faster response. Comparing to the detection of the brain response by EEG, we find that, if comparing to the electrostimulation, the stroke persons can perceive the vibration much faster. So it is a faster response. Therefore, this is the reason why we give the vibration here. It is because it can trigger the faster cortical response and the immediate correction of the wrong step. And then similarly to the upper limb, we also explored the possibility or feasibility to use the lower limb device in the telerehabilitation. But one more thing is more funny. We just pair 2 different persons together in the training progress, and so that the patient can support to each other in the long term. Why we call it the long term? It is because usually one program consists at least 1 month's training. And some of the patient, if they stay at home without a professional at the side, they is easily to drop out. And in order to improve, to keep the patient in the training and improve the compliance, then the professional remotely coordinate the 2 patients together and synchronize their training progress. And they can communicate remotely and through the WhatsApp or any social media or communication platform we available nowadays. And then the device also can continuously record the training progress and the task completion situation every day, and give us the report. And we found that after 20 training session, 1 month, the majority of the stroke patient is chronic. They are at least the after the onset, at least I think larger than 1 year. Majority of them can achieve the overall overall walking capability improvement measured by the clinical score for 40%. 40%, okay. And this improvement can kept at least 3 months after training. And also, we find that the correction of the foot job is also significant. Okay, the dorsiflexion angle after training can be doubled. Although the normal range should be achieve the 15 degree of the ankle angle, but the improvement for 1 month treatment is also significant, and almost 90% of them correct the foot inversion after training. And the video shows the comparison of the patient, okay, before and after the training. You will find the gait pattern is changed. The green leg is affect the leg. Okay, you will find before the training it has a very obvious, okay, the ankle, it has the rotation, okay, the rotation. But after the training, you will find the pattern have become corrected. So, and since we put the device to patients' home, we did not follow them, but some of the patients just send us the videos. They observed the improvement before and after training. And you will find that this patient before the training, okay, the compensation is quite large, is because you'll find that, okay, this kind of the up and down. That is because first is the lack of the probation in the lower limb, and also the compensation of the body trunk. And after training, you will find that the probation is appeared, although it is not fully recovered, but you will find that, okay, comparing to the pre-training and the probation phase were established. And also, the walking speed is also much faster. And when the patient is not confident in their walking, they usually don't want to go out. It is because Hong Kongers are usually walking very fast. But they cannot walk fast. They are scared to be bumped into and falling, and they will like to stay at home. And the other part, okay, the other part actually shows how the patient just using our device, okay, to practice the gait in a park near his home. So this is the scenario. Because the lack of sound, actually our device, okay, our apps can give immediately the verbal feedback. If the device detected the imbalance, okay, the imbalance in the plantar, then we'll remind them, okay, you need to correct your foot balance. And if practice for 15 minutes, then the apps also will remind, okay, take a rest. Okay, so just like the coach, a coach to the patient, individualized the coach to the patient, and by using this sound feedback and the device, the patient can practice in a relatively open area and also relaxed and flexible time. And this is another the patient feedback. And this gentleman, before the training, you will find that the walking speed is very slow and not very confident. But after 1 month training, you will find the gentleman walking more, rely on himself rather than on the stick, and also much faster. And by using our device, it is because our device is IoT device. Okay, when doing the training, during the conversation with others, all the records will be recorded, okay, collected. And we also use AI, ChatGPT, just to classify what is demands of the clients during the whole period of the training. And we grouped the informations in different categories. We find that majority of the demands of the clients actually is not related to the professional issues, just related to the administration on the arrangement of the training and how the logistics, and also contains the conversations unrelated to training. And we find that, okay, we calculate the percentage. Only 20% of the demands raised from the clients need the help from the OT, from the professional, healthcare professional. Only 8% is related to the device, needs engineer support, but the others may not need the professional support. Just admin assistance is enough to handle. Okay, so and that is the story of our lowering, and also I would like to share the owners of our projects received that, okay, the lowering has been received the CES Innovation Award this year, and also has been recognized as trending now story in the global market of the rehabilitation robots. Yeah, so these are the, and yeah, so there's another certificates we, I think the device obtained so for the upper link and the lower link. Yeah, so these are my teams. Okay, without them, these talents, okay, we can achieve so much. So I think it's almost 1 hour. Yeah, so I complete here. Thank you. So any questions? So for online, any questions? How much about any? How much? How much is the cost? So, okay. I'm a major stroke rehabilitation patient since 1997. My right side is affected, quite immobile, with an assistant feet guide, and my right finger are still immobile. I'm hoping that the new innovation from the words will help me to further. Is that possible? Answer left. So actually, if you would like to join our clinical trial, you are always welcome. You can just send email to me, and then I can find a suitable program for you to join. Is that okay? Okay, how much about the NES robot? The upper link currently have the price in Hong Kong is around 50,000 to 80,000. It quite depends on what kind of module you would like. If you are interested, you also can send email to me. I can forward you to my company, my industry partner. Is that okay? And if case is chronic stroke, more than 3 years. Yeah, okay. Actually, the participants in our clinical trial, they are very, very chronic. Some of them even chronic survived for suffered the stroke impairments for 10 years. So 3 years is still I still think as a quite short period of time. Any case or contrary using NS robot. Oh yeah. So actually, for the inclusion criteria in our clinical trial, usually we will exclude the patient with epilepsy, and also with the pacemaker implanter. But the others usually should be okay. Can use our device. And spastic hand. In case with spastic hand, still suitable for using robot hand. Yes. Actually, the spasticity usually experienced in the flexor rather than extensor. And in our multi-channel electrostimulation, we can turn off the stimulation to the flexors, but turn on the extensor. Yeah. So it is adjustable. If using robot hand, you suggest the best frequency and the duration per week. In our clinical trial, our training intensity usually is 3 to 5 sessions per week. In each session is around 1 hour. And the case shown in the video, how long the case suffered from the stroke within 1 to 3 months. Actually, all the case I show here, they are chronic stroke patient. That means they at least 6 months, at least 6 months past the onset of the stroke. And this robot can apply on thigh muscle. Currently, the stimulation intensity is just targeted for distal muscles. For the thigh muscles, usually it will cause pain. It because the stimulation is quite strong. So we have not tried for the thigh muscle. Send for your assistant via email for those who are on stroke recovery. You can actually. I think the lecture will. I think the course Fanny assistance Fanny will provide our contact to you. You also can search my email by visiting my website. It is public. You can just type my name. You can find my email. If metal implanted inside the hand, still use robot. If you have the implantation, particularly closer to the stimulation side, then it is not recommended to use the NS robot. But you can our robot integrates the electrical stimulation and mechanical support. If the mechanic only use the mechanical support, you still can use even you have the metal implantation in your hand. Yeah, and for those who have both mobile problem, both on hand and foot, will they give recovery for both at the same time? Oh, yes. Actually, currently we have a new clinical trial that is to study use the upper and lower limb robots at the same time to recover the upper and lower limb. Yeah, both. Yeah, so yeah, so that's all. Okay. Any trial on shoulder muscle? Currently, no. We mainly target on the distal rather than the shoulder. Yeah, so that's all. Thank you. Any questions from the audience? If no, then we may. Yeah, we have a break.
So it's 7:40. Let's get started. Welcome, everybody, for those who are here and those online. It's good to see faces on a Friday evening. Thank you for coming and joining the course. Let me introduce myself a little bit. Okay, I am Elaine Kwong. I am a speech therapist by training, and if you could see, I am coming from I'm from the Department of Chinese and Bilingual Studies. That was the past. We have now renamed to the Department of Language, Science, and Technology. Okay, so our new department. So we are under the Faculty of Humanities. So you may wonder what does a humanity faculty member has to do with innovation, technology, etc., etc. So I hope in the next 40 to 50 minutes, I can convince you that innovation is basically everywhere. Okay, and I'm a speech therapist by training, so I am looking at innovations for smart aging from the perspective of a speech therapist, and I'm also glad to be the associate director of RISA. So happy to see you all. So before we get started, let's limit the scope. And I'm sorry that I have to sit to do this little sharing because I'm afraid that I will pass out because I'm still recovering from a very bad flu. So please bear with me. I have to sit down to do this little presentation. And so I want to keep this session as casual, informal as possible. So if you have any questions, comments, and online, just let me know. We'll try to address that throughout the sharing, okay? So aging is a thing in speech therapy. I'm not sure if you are aware of what is speech therapy. Actually, are you familiar with speech therapy? 语言治疗, 言语治疗. Because in the past decades, I think the awareness of speech therapy in the field, in the population of child, is increasing. But for aging population, for the older adult population, actually we really play some significant roles as well. For example, in two major domains of aging, older adults often have difficulties in communication. I'm not sure if you have dealt with elderly having aphasia, that is language problem after like stroke or other brain damage, or dementia. Okay, they could have communication problems. And of course, the communication problems can be further divided into language problem. So they may be unable to find the correct word for that concept, or they may have slurred speech. So it's a speech problem, pronunciation problem. And their voice, especially for those with Parkinson's disease, their voice may become really soft and robotic and monotonic. Okay, so voice actually is part of communication. And yeah, our older adults actually have problems in that. And of course, hearing is not, it's quite understandable that hearing will deteriorate as a person ages, okay? So communication. And on the other side, on the other arm of this little chart is swallowing. So swallowing is actually managed also by speech therapists. Okay, and swallowing, I would say, is a huge part and has some very significant impact on one's health, first of all, and also quality of life. And we'll discuss about that later. And yeah, my research interest is mainly on swallowing. So I'll talk more about how we try to apply technology to swallowing management in this session. Before that, let me give you some background information about swallowing. And I will also bring up the term dysphagia very frequently, because dysphagia is actually the medical term, the proper term for swallowing disorders, okay, swallowing problems, dysphagia. And actually, one may think that dysphagia is something to do with choking, with the swallowing part at the throat, something like that. But actually, it's more than that. By definition, swallowing problem or dysphagia is defined as any abnormalities that occur after the food or drink has entered the mouth and before the food or drink has arrived at the stomach. So it could happen at any point between this relatively long pathway, okay, passage. And the prevalence, the percentage of having dysphagia is maybe surprising to you. So it's not really that uncommon. So it's not figures from Hong Kong, but from a systematic review, an author reviewed different populations, different population in different countries. Okay, so the general population, adult population, of course, not only the elderly, of having dysphagia could go as high as 13.4%. So 1 in 6, 1 in 7 of the general population could have some form of dysphagia. So it's not as uncommon as we imagine. And if we particularly focus on older adults, percentage go as high as around 1 in 2 older adults, okay? And if we focus on stroke survivors, more than half of the stroke survivors have some form of dysphagia. And other neurodegenerative disease like dementia, Parkinson's disease, or other brain trauma or brain tumor patients, they have even higher prevalence rate of dysphagia. So it's really a big issue to me and also to the society, to our healthcare system. So in Hong Kong, we don't have a really systematic figure, but in a study conducted, I think, about 10 years ago, Actually, in the long-term care settings, for those who are living in long-term care settings like nursing homes or elderly homes, the prevalence of having dysphagia is high, 61%. And even for those who are not really residing in the long-term care setting, they are going to daycare centers, okay? They are only receiving day care, but not overnight residential care. Prevalence can still be about 41%. So it's, yeah, significant to me. So what will happen if a person has dysphagia? First of all, malnutrition and dehydration cause the intake is poor. So the person may not get enough hydration, may not get enough water, and also the nutrition level may be very reduced. And this could be very detrimental in older adults, especially because they are less, I would say, less flexible than we adults in terms of balancing and managing the homeostasis in the body. So dehydration and malnutrition could lead to very serious health problems. And other consequence that could be life and death is aspiration pneumonia, 吸入性肺炎, 吸入性肺炎. Okay, so pneumonia is severe, okay? And if the person is having dysphagia and still eating some difficult to manage food, okay? The food may just go into the airway, choking may occur, and that foreign body going into the lung may cause pneumonia, and that could be life and death. And other level of problem will be social and emotional problems, especially in the Chinese culture, because we take eating as a blessing. We like to eat with families. We enjoy meals and the dinners, especially in festivals. So not being able to join in, dine with your family or friends could lead to severe, psychological and social problem. And all of this, of course, will reduce quality of life in both patients and caregivers, because we have been receiving not complaints, but comments, okay, from caregivers that, oh, it's really tiring and time-consuming for me to prepare special food for dysphagic patients, things like that. And we always have to think about, okay, what they can prepare for dinner, et cetera, So it's a burden, definitely, to both the patients and the caregiver. Some background information. So after listening to Professor Hu's talk, I am not as scared to talk about technical and physiological terms, okay? So I want to introduce some background information first before we go into what exactly I have done in the past few years in managing swallowing, okay? There are, in general, 4 stages of swallowing. So stage 1 involves oral preparatory phase. So what is meant by oral preparatory? Anyone on Zoom? So before we can swallow a bolus, a food bolus, or a drink bolus, anything, okay? Before we swallow, we have to do some chewing, right, or mastication. So we have to prepare the bolus so that it is ready to be swallowed, okay? And that preparation involves, of course, chewing. And chewing is not a simple movement, okay? It involves like up and down movement of your jaw, crushing of the food using your teeth, especially the molar. And the tongue actually has some rotationary movement so that we can like make the bolus into one little ball-shaped thing. And also we mix the food with saliva. So you could imagine if we are preparing, we are chewing some cookies or biscuit, okay? We can't just swallow it, even if it is very, minced, it is in very small pieces. No, we have to make it moist enough to pass through the larynx, the pharynx and esophagus, etc. So we have to mix the bolus with saliva, and this all happens in the oral preparatory phase. Okay, so stage 1, preparatory phase. And once the bolus is ready to be swallowed, phase 2, the oral phase kick in. Oral phase means that, okay, we have a ready to swallow bolus, and what do we have to do to swallow it? Where should we move the bolus? To the back of our mouth, right? So posterior oral movement. So the oral phase is relatively simple. It's just moving the bolus to the back of our mouth in order to trigger phase 3. And phase 3 is quite reflexive. Okay, we can't really have voluntary control over phase 3 because once the bolus reach the back of the mouth, phase 3, the pharyngeal phase will kick in. And the pharyngeal phase is super important because most of the aspiration, most of the choking occurs at this phase. Because during the pharyngeal phase, there are a series of complex and well-orchestrated movement occur there. Okay, first of all, we raise our larynx. Okay, I always ask the participants or students to do this. Try putting your fingers on your neck and do a dry swallow. What can you feel? What is happening? Can you feel something, elevated, moving upward and then down? So that's a very important movement. Okay, that's laryngeal elevation. We raise our whole larynx in order to better protect the airway, to prevent food from entering it. And of course, there are some invisible movement like the epiglottis will cover high school biology. The epiglottis will cover the airway, and then the larynx will move upward so that the airway is well covered. And also, the vocal cord, our voice box, will close as another gate of safeguarding the airway, so forth and so forth, okay? So pharyngeal phase is complex and it is very important for airway production. And if there's any problem happening at this phase, it will probably lead to aspiration, okay? So not good. So after that, after the bolus has entered the esophagus, it's more about squeezing and movement of the bolus towards the stomach, okay? Again, that's quite reflexive and we don't really have control over that. So 4 phases of swallowing. And of course, anything happen to any of these movements will cause choking, which is not good, suffocation from choking. That may be like immediately life and death. And aspiration pneumonia, again, not good. Further, more long-term consequences, malnutrition, dehydration, even death. I think we have talked about that. But I think it's important to also to take into consideration about the quality of life thing. So what is actually the problem here, the problem to me here, especially in the community settings in dysphagia management, is that dysphagia or swallowing is so invisible, it's so internal. So we need something to visualize it, right? In order to do assessment, diagnosis, or management. So the problem of, okay, I've got a question here. What is the function of vocal cord during swallowing? Actually, if you could see me on the camera, the vocal cord is about here. So its alignment is like this, horizontal. So when we swallow, we can't breathe because the 2 vocal folds will close, will touch upon each other and close the airway completely. So this serves as the 3rd protection mechanism of preventing foreign bodies to enter the airway. So that's the role of the vocal cord, okay? So let's get back to this. Imaging, especially in the community, because let me introduce what is happening currently, the status quo. There are some mainstream swallowing assessment imaging techniques, basically. So number one, which is regarded as the gold standard in swallowing diagnosis, is the video fluoroscopic study of swallowing. Don't worry, VFSS. Okay, VFSS. It involves X-ray. We take multiple X-rays pictures, okay, when the person is doing a swallow. And the food or bolus that the patient is swallowing has some contrast agent added to it so that it's visible on X-ray. So it's like the old day cartoons making, okay? We take multiple sequential pictures, X-ray pictures of the swallows, and then we can make it into a video so that we can look at, okay, the internal structures, how, for example, is the bolus going into the right place, or is the epiglottis covering the right at the right timing? Did the larynx elevate adequately, etc., etc. So VFSS using X-ray. So can you imagine what could be the problem? Apparently there are limitations, right? It's a gold standard because we can really visualize the bolus, we can detect aspiration very easily, but what is the limitation, or what are the limitations? Do you like X-rays? Multiple X-rays, okay? And first of all, radial actively invasive, so we can't do it repeatedly, we can't do it all the time, right? And second of all, we can't do X-ray anywhere, right? We can't do it here, we can't do it on the podium, etc. We need a special facility and venue to do the X-ray. And that special venue and facility usually can only be found in hospitals. Okay, so it's really not available, not accessible to patients, especially those in the community setting. Okay, the second mainstream assessment method will be fiber optic endoscopic examination of swallowing. And don't worry, FEES, okay, F-E-E-S, FEES. There's a word, endoscopic here, so it involves passing through a flexible, not a rigid, flexible endoscope, which is about the diameter of a spaghetti, okay? Passing the endoscope, spaghetti-like endoscope, through the nostril, and then going through the nasal cavity, and then bend a little bit so that the endoscope can have a view of what is happening in the pharynx or at the level of vocal cords, etc., etc. So when the camera is there, when the endoscope is there, we ask the patient to swallow something, and then we can visualize, okay, where does the food goes? Is it going into the right passage or something like that? Or is it going into the airway, something like that, okay? Again, it's a gold standard. It's very reliable because we are really visualizing things, okay? But limitation? Can you imagine passing a spaghetti through your nostril for a couple of minutes? Okay, so it could be quite uncomfortable, invasive, and even unacceptable to some patients, especially those with dementia. Okay, so we don't recommend, I mean, they don't prefer doing this. And okay, so what do we do in the community? And also the instrument, okay, the endoscope could be quite expensive and cannot be operated by anyone, okay? So we need a trained personnel to operate that. So these are some disadvantages. So what do we do, or what do the speech therapists are doing currently in the community? Palpation, observation, okay? So we do it, we call it the clinical bedside swallowing examination. So basically we put fingers, just like what you did, on the neck area and feel and try to guess or infer, okay, infer is a better term, but yeah, basically it's guess, guessing the movement, internal movement of the pharynx or the structures internally. So limitations? Cannot see the internal structure for very true. We can't see what is actually happening there. Okay, number one. Subjectivity could be an issue. Okay, what I'm feeling could be different from what you are feeling just now. Okay, so subjectivity and also, yeah, reliability. We may be missing a lot of information. Okay, bedside, clinical bedside examination. So this is what we got currently. And it's not, it's far from optimal, I would say. Okay, so we basically use the clinical bedside examination, accuracy, subjectivity are the issues, and we don't really have on-site instrumental examination in long-term care settings like nursing home, like daycare center, etc., etc. So they usually are referred to the hospital, and usually the public ones, because not many of them could afford private hospital visits, right? And to get those imaging sessions. But you could imagine the long waiting time, limited times lost, etc., and the traveling nuisance could be, could be quite tedious. So, and also, so these are not really options for the community dwelling individuals, okay, elderlies. And actually, there are consequences of not having instrumental assessment in the community. So if we rely too much on the clinical bedside guessing examination, what will happen? First of all, the speech therapist may be overly conservative in managing dysphagia. For example, because we don't see what is happening here inside, so the speech therapist may say, okay, we better play safe. That okay, we recommend non-oral feeding. I recommend a nasogastric tube, 鼻胃管, 鼻胃喉, for the person. So you don't have to swallow. You cannot eat orally. Okay, overly conservative management recommendation, because we don't have access to instrumental examination, and or they may be overly prescribed, recommended of diet modification. For example, I want you to be safer when drinking water, so I ask you to add thickener to thicken up your fluid before taking, or I recommend pureed diet. For a patient who may or may not need pureed diet, so high prevalence of modification. And by diet modification, is a hot topic currently. A lot of patients the public awareness campaign has been conducted to get people to aware of the unappealing appearance or of the modified diet, the pureed diet, for example, in the middle, and the minced diet, and also the nutritional value could be diluted throughout the process of blending and chopping up the food. So another loophole of malnutrition, etc. So we definitely want more instrumental assessment at the community setting. And if we have instrumental assessment available, actually 3 major benefits may result, okay? We can have better quality of life, and eventually we can have better or reduced cost spent on healthcare, both at the centers, okay, the NGO centers, and also at the hospitals. Because we can have better diagnosis, we can have better treatment plans, better recovery and rehabilitation, okay? And An instrumental assessment, okay, may also reduce emergency department admission, okay, less admission through the ER. So a couple of benefits, okay? So this is a problem. We don't have available, accessible, and non-invasive assessment. Let's talk about non-invasive first. But we have very limited access to instrumental assessment, imaging assessment in the community. So we looked at some not new, but old technology, but with some new application, ultrasound. Okay, anyone in the audience have gone through ultrasound assessment? Me, a couple. So it's quite common, popular, right? And is it painful to do that? Non-invasive. Are you worried about radiation? No, we don't. And do we have to wait for a long time to get the assessment? No, because it's not, I would say it's quite cheap as compared to the X-ray facilities. And yeah, it's not uncommon to find, right? So we looked at ultrasound and we explored if it is applicable to swallowing management. So it's non-invasive, so we can allow repeated examination. We can access it everywhere, basically. And we allow on-site instrumental assessment. I always show this picture to the audience to indicate how portable ultrasound could be. So this is the portable ultrasound device or system that we sometimes use clinically. So we can bring the system basically everywhere, to the home of the patient, to the elderly centers, and we also do it in the expo center in Wan Chai. This is the Geron Technology exhibition a few years ago. So it's very portable, allow on-site instrumental assessment. So patients don't have to travel all along to the hospitals for assessment, okay? And of course, there are a couple of other advantages. So we introduced the concept of point-of-care ultrasound to speech therapists, okay? So traditionally, we go to the exam room, seeing a sonographer or radiographer to get the ultrasound assessment. And then the sonographer will write the report and send it to your doctor to explain to it, right? That's the traditional ultrasound. And point-of-care ultrasound means we don't send patients to the room. We are the one doing the scanning. We speech therapists or the other healthcare workers. And because I know the patient quite well, very well, okay, so I can integrate history of the patient and feeding observations, physical examination, the palpation, plus the ultrasound images all together to do my diagnosis and to do my assessment. So it's holistic, right? So point of care ultrasound. I bring the ultrasound to the point of care. It could be the home, it could be the nursing home, it could be other daycare center. And, but there are some gaps in point-of-care ultrasound POCUS in swallowing. POCUS is not a new thing. I did not invent that, but POCUS in swallowing is new. It's a new concept. It's so new that we are still lacking some evidence, clinical evidence about what to measure and how to measure. So we don't really have protocols. We don't have a standard guideline yet to do the ultrasound, point-of-care ultrasound in swallowing. So that's my inspiration of my research, okay? So let me show you some images. This is an image, a video obtained through the X-ray, okay, VFSS. And there are some movement of interest in swallowing that is particularly interesting to speech therapists like me. You could see, I hope you could see that. Look at this vague shadow, okay, of the black light. It is actually the larynx and etc. So you could see this larynx, 喉嚨, 喉, is having a upward and forward movement. And we call that laryngeal excursion, okay? Or more importantly, we want to see one of the bones, the higher bone in the larynx, okay? How it elevate, how it go forward and upward, okay? That's number one. And other thing that we are interested in is the tongue-based retraction. Remember the oral phase, we need to push the bolus backward into our larynx. So we look at the tongue, okay, and see if it is good at retracting. It's good at like backward posterior pushing of the foot bolus. So these are the two main things that we investigated initially, and they are very significant to swallowing safety. Okay, so you could imagine if you have the tongue-based retraction too early, that the larynx is not elevated soon enough, okay, then the airway is wide open and then aspiration will just occur. So we need these two major movements to be well coordinated and have adequate range of movement. So this is what we see on an ultrasound image, okay? We put the ultrasound probe on the area, submental area like this, and then we could capture images like this, okay? So I want you to pay attention to two things, okay? First of all, this white bright line is the tongue surface, okay? The bright line. And also there is a shadow here. It is actually where the higher bone is located. So tongue, base retraction, higher bone, elevation, okay? So pay attention to these two structures. And on the video, okay, when a person swallow, tell me what happened. What will happen to the tongue, the bright line. I'll play the video now. Pay attention to the tongue surface. Oop, done. What happened? Swallow, done. What did the tongue do? A wave, very good. A wavy movement, smooth, fast, timely, good, okay? So it is a healthy subject, okay? The tongue will have a wavy, fast, and sharp movement, and that corresponds to the tongue-based retraction. So let's watch this video another time. Pay attention to this shadow this time. Shadow, okay? Tell me what happens to this shadow. Oops, done. Do it again. During the swallow, what happened to this shadow? Where did the shadow move? Yeah, towards the left, right, on the image. See, it's not difficult to interpret at all. Okay, even with very little training, okay, it's quite understandable to lay persons, okay, to clinicians and to patients. So it's very reader friendly, I would say. So this is, I think this exemplifies, this shows how applicable it could be of this ultrasound technique to assessment or examination of swallowing. Of course, there are other structures or movement that we will look into, but yeah, these two are quite well established. So we look at, like, number one, the spatial information. If I will look at if the higher bone, the leftward movement is adequate, or if it is coordinated in terms of time, okay? And from an early study, we found that in healthy subjects, non-dysphagic subjects, they follow generally a sequence, okay, of having TB is tongue base retraction. HB is higher bone elevation. So most of them, in order to have a healthy and good swallow, safe swallow, they move their higher bone first. They elevate their higher bone first, okay, before they retract their tongue. So this ensures very safe swallow, okay? So there is no chance that the food bolus will enter the airway like this, okay? So first of all, I think ultrasound and also the parameters that we can extract from ultrasound images could be useful for speech therapists in diagnosis. You could imagine if a person, okay, if I scan a patient, if I could see the tongue base is moving earlier on than the higher bone elevation, oh, that is not safe. That could be problematic, okay? So it could be applicable to clinic. And we also found a general sequence to be followed. And so that was on some healthy subjects. So we really investigated that if these temporal time measures, time parameters could help us to differentiate among different people, okay? Healthy, dysphagic, and also non-dysphagic, but aging people, okay? And this is what we found. I won't discuss the graph into details. We used some indices, coefficients, and we found that, yes, these indices and coefficients could help us differentiate the three groups: healthy adults, healthy aging adults, and also the dysphagic adults. So we found more parameters for us to use in clinical application. But the problem here, number two, is what we did is some manual frame by frame, annotation. We have to look at the ultrasound images one by one. And for one swallow, it could involve like hundreds of ultrasound images and do the calculations, marking one by one. So it's very labor intensive and it's not practical clinically. We don't expect a speech therapist to do like manual annotation. So anything we could do to help us translate into clinical practice. So we tried automated tracking, okay? So remember, what is this shadow referring to? Is it important, this shadow? Actually, this point, sorry, I should be pointing at this shadow. Actually, this point is exactly where the higher bone is located. The other is just the shadow behind the higher bone. So we looked at some automated trackers to see if we can track the higher bone movement in some swallows. Look at the pink box. It's trying very hard to follow the shadow throughout the movement, right? And it's automated, it's not manual tracking. So we asked some algorithms to do the tracking for us. And if we can do the tracking automatically, we can automate the tracking, we can convert those tracking into some meaningful and quantitative data in temporal, in timing, and also in spatial data. So algorithms helps us to do some real-time analysis. And we studied a few trackers and we found some high accuracy rate of tracking. And we located a few trackers that we may develop into further automated tracking. Okay, so this is doable. And there are other studies done by different research groups. They are also working on some automated tracking of the higher bone, since it is a very important structure and it reflects the swallowing safety a lot. And it's very easy to identify. Even you can identify in no time, right? So a lot of studies has been published to see automated tracking automated segmentation or annotation of the higher bone. And there's another interesting study that also used automated segmentation, but this time it's locating not the higher bone, it's locating the footballers on ultrasound images. But yeah, if you are interested, feel free to look into that. So there are research groups doing working on that. So first step of solving a problem, making it practical, making it translatable to clinical practice. Okay, we can have automated segmentation tracking. But that's not the end of the story, okay? And there's another study comparing human detection and also AI detection of aspiration on ultrasound images. And again, it's an interesting read, but I won't discuss this publication here. But yeah, I refer you to this very interesting study. So based on what we have collected, the temporal or temporality measures, we try to solve the second part of the problem, okay? We try to identify machine learning algorithms, AI, okay, to help us to do the diagnosis or classification, okay? So we studied, we collected ultrasound images from about 100 participants. We have young, healthy adults. We have healthy older adults, and we have dysphagic individuals. Okay, so 3 groups of data, 3 groups of subjects, and we evaluated a few algorithms using stratified 5-fold cross-validation. So if you're interested, Google it, okay? But the objective of the study is we want to see if we can classify healthy versus dysphagic. I mean, if the AI algorithms could classify healthy versus dysphagic, okay? And this is how we evaluated it, okay? AUC-ROC is a common metrics that we evaluate the algorithms or assessment tools, okay? And yeah, we do find 2 algorithms that achieved AUC area under curve of over 90%. So the higher, the better. Over 90%, that's not bad, right? And if we took a closer look to the metrics, we found that the support factor machine, okay, that's the 4th one, has a good AUC over 90%. And also it has a low false positive and low false negative rate. So it could be a candidate, is quite nice, okay? And yeah, in terms of differentiating healthy and dysphagic individuals, okay? So it's, again, doable. I won't say that it's solved, but it's doable, okay? Using AI, using technology to help us to do automated classification, healthy versus disordered or dysphagic. But then we, as clinicians, we have to think deeper and think further, okay? I want to make a diagnosis, but I want to know why that diagnosis. Is it due to poor hyoid bone elevation, too slow, the elevation, or is it is the tongue base retracting not enough, et cetera, et cetera. So we want to explain why that diagnosis, why that classification. So we looked into the explainability. Okay, we can't just believe in the AI saying, okay, this is dysphagic, okay, this is healthy, and that's the end. No, we want to make sense of it so that the clinician can study, can plan treatment accordingly. So what is actually causing the dysphagia? So we use, again, metrics to look at the explainability of the algorithm. And we found that it's quite close to what we human eyes are seeing, okay? For example, we look at the, let's skip the anatomy part. But anyways, yeah, these, the support vector machine is having good performance plus having not bad explainability. So we can make use of this algorithm to help us to guide treatment. Okay, then we can use like technology to help us interpret the diagnosis. So that's what we have tried to again make sense of or help the translation of our studies into clinical practice. I prepared more, but I want to move to the last part first, because I have a third problem. So I know how to diagnose, I know how to interpret the results using from the that we get from AI. So can we innovate the treatment for dysphagia using ultrasound and also the advancements? Okay, before that, more background information. Actually, we have two major approaches to treat dysphagia. Number one is compensatory. That means we don't really work on the physiology. We don't expect the swallowing function to improve, but we work on what is happening as a side product. First of all, for example, we modify the diet. We add thickener to the drinks so that the flow rate will be lower and the patient could have more time to elevate their heart rate, etc. So diet modification and posture modification. For example, if there is a weaker right side, we may ask the patient to turn their head to their weaker side so that the protection will be better. Things like that. So compensatory kind of movement, kind of treatment, number one. And number two is rehabilitative treatment. And for this, we really want to improve something, improve the physiology and function through asking the patient to do exercises and training to strengthen the muscles, etc., etc. But at the end of the day, both approaches aim to reduce the risk of choking and aspiration. That's very important, safety, and to enhance intake of food and drink. Again, very important, nutrition and hydration. So these are the ultimate goals for dysphagia treatment. So if we look at the rehabilitative approach, there are a couple of exercises that clinicians, speech therapists can adopt to help training to strengthen or to improve the swallowing function. And we took Mendelsohn maneuver. It's a fancy name. Mendelsohn maneuver as our exemplar swallowing exercise or maneuver. Because it has some good advantages. For example, it increased the duration and placement of higher bone elevation, swallowing safety, and it also helps opening up the esophagus upper opening. And again, that will ensure the food can go into the right passageway, okay? But what exactly, yeah, and of course, safer swallow. So let me tell you how Mendelsohn maneuver is done. Listen, okay? Mendelsohn maneuver, you have to elevate your higher bone, the whole larynx, and maintain it at the maximum point for at least 2 seconds before you relax, blah, blah, blah. Can you understand? Can you do it? Okay, that's the instruction that we can give to the client, our patient, okay? Because that is what is happening during Mendelsohn maneuver. No, it's difficult. So we have to look for ways to facilitate our training. So we need biofeedback. Again, ultrasound has a bunch of advantages, okay? So we reckon if it could be a good and efficacious biofeedback for us to train swallowing movement. Okay, so we compare ultrasound with the traditional biofeedback. I'm glad that Professor Hu has introduced SDMG to you, okay? So you are familiar with that. So traditionally, speech therapists will place electrodes at this region, and the patient will look at the waveform to study, to know, okay, the muscle activation, et cetera, but still very non-intuitive, right? Okay, and we studied ultrasound. Okay, so we let patients, even stroke patients, even mild MCI, mild cognitive impairment patients, okay, we ask them to look at the ultrasound images and we ask them to focus, just like what I did, focus on this shadow. And after some introduction, we get them to look at the image and do the 2-second holding, swallowing maneuver, Mendelsohn maneuver for us. So this is what they could see. Okay. Oh, I should be pointing at this. So focus on this shadow and get the shadow. I asked the patient to get the shadow, move to the left and hold it for at least 2 seconds before you allow it to depress. Okay. Holding. Relax. And this is very intuitive to them, and they can do it quite well. So the data told us that given comparable amount of practice time, the SCMG group, the blue bar, and the ultrasound group showed very significant performances, okay? And of course, the ultrasound group outperformed the SCMG group a lot, okay? So that's a piece of evidence that, okay, ultrasound, a relatively new modality, new tool in swallowing could be applied to, could innovate treatment approaches, okay? So to sum up, I guess what we have done throughout the year, it allows instrumental assessment to be done not only in hospital, but in community setting, which could be beneficial to our older adults. And it supplement what is usually done by clinicians, the palpation, guessing thing, okay, to increase diagnostic accuracy. And it helps us to identify hidden cases in the community. That's very important, okay? So hidden cases are not assessed before, they have never received any services, okay? But with the help of ultrasound, hopefully we can bring the assessment tool to them. And of course, treatment efficacy. And at different levels, at the individual level and at the organizational level, we can have a better resource allocation. For example, a nursing home, okay, with a more accurate assessment result. They may spend less money on thickener. They may spend less manpower on chopping up the food, right? Because actually the patient doesn't need the chopping up. And of course, societal level, the overall burden of the medical and healthcare system could be reduced. And of course, with the help of AI and other technology, the improvement, the benefits, we are hoping to have more impacts or better improvements, greater improvements. So this is what I would like to share today. And I've got some questions here. Okay. Sorry, Professor Jiang. So a question here is, in fees, the flexible endoscope, how low will the endoscope go down to? We can go as low as before touching the focal folds, okay? So it's about this level. Because we want to look at because below the focal folds, it would be very irritating and invasive. We go through the focal folds. It's not tolerable at all. And we are most interested in what is happening above the focal folds level. So we usually can go as low as the focal fold level. Ultrasound common used in community, that's the plan. And that's what I am trying to do in terms of knowledge transfer. Sadly, it's not common yet, but I am working hard to do training for community speech therapists and to help them to acquire the equipment and provide consultation to help them to apply ultrasound in their clinical practice. So I hope it will become common very soon. ST in Hong Kong can perform ultrasound. I guess yes. But we have to pay attention that we only use it for our ST-related assessment. Okay, so we don't make diagnosis on like thyroid gland abnormalities, etc. So we don't make medical diagnosis, but we focus on what we see in terms of, for example, swallowing function on ultrasound images. Okay, 70% of the case with dementia will have dysphagia, underlying mechanism. Because dysphagia, if we look at the neural pathology of the dementia, it involves some general atrophy or pathology in the brain. So dysphagia actually, just like other movement, okay, the upper limb or lower limb movement is highly controlled by our central nervous system. So any damage, even minor damage to the central nervous system could have an effect on swallowing. Contraindication of using stimulation over, yeah, using I guess the question is more about using ultrasound, right? Because at this stage, we don't really, there are other studies, other clinical application that uses electrical stimulation on swallowing muscles. There are some, but what we are trying to do is to use an imaging technique to help us to visualize the swallowing function. And even for this, I have tried to look into contraindication before. It's quite safe, okay? Ultrasound is quite safe. But we do, we have encountered 1 or 2 cases that those pacemaker implanted patient, okay? Because some of the devices nowadays, they have wireless charging and they have some magnetic field out there. So there is 1 or 2 cases that we saw. The pacemaker may be interfered, but yeah, but there is no empirical evidence to say that. So for simply speaking, ultrasound is safe for basically everybody, as long as there is no active unhealed wound, because we apply gel, aqueous gel on the region. So if there's wound, obviously it's not recommended. Otherwise, it's quite safe. But we have to be aware of the wireless charging system or other transmission system and how they interfere, how they interact with implants, okay? Exercise to swallowing muscle frequency, duration, intensity. We are not there yet, so we are planning to do more randomized controlled trial to look for a standard protocol for exercises. But of course, the more, the merrier, okay? A very short answer. But there are other factors affecting efficacies. For example, plus or minus biofeedback, plus or minus clinicians' feedback, and how frequent do we give feedback, or how specific are the feedbacks. They are all interacting factors that may affect efficacy. So stay tuned. We hope to have a standard protocol coming soon. Okay. So I guess that's all for now. Any questions from the floor? Comments? If no, shall we take a short break of 5 minutes before I pass the mic to Professor Zhang?
Since Professor Kwon, Elaine just discussed about ultrasound, so many of you maybe have a good sense, okay? And also, for swallowing is some kind of new and innovative application. So I'm also collaborating with Elaine's team. So this is why that part I will skip here, but because that part is also muscular part, okay, or neuromuscular part. So overall, I wish I will give you an overall understanding about what ultrasound can do for neuron and muscular. So when I say neuron here, specific for brain, today I will discuss with you, and also muscle. So basically it's brain and muscle ultrasound. So I'm so happy that earlier Elaine received so many questions related to ultrasound. So I hope that I can let you have a better understanding about this. So this is really the two areas that we want to tackle, while ultrasound can definitely be used almost anywhere, from the head to the toe. Okay, so this is how ultrasound have. So as you've seen here, I'm mainly focused on sarcopenia assessment, stroke, Parkinson's disease, and dementia. That is inside the brain. Okay, inside the brain. But certainly outside the brain, all the muscle will be musculoskeletal, muscular system. As Elaine mentioned, that is for swallowing. And later on, we'll also show you, probably I have slide for the tongue assessment that is related to speech disorder. So we all know that we have a lot of peaks, okay? So one peak for the muscle strength, muscle quality, actually is very early, okay, as you can see, okay, in around the year 30, and then gradually reduce, okay, continuous reduce. So nowadays, actually, sarcopenia, the muscle loss, is become much more important than osteoarthritis, osteoporosis. Okay, so because muscle loss, muscle weakness actually can cause OA, osteoarthritis, and also the osteoporosis. So the bone loss or the joint disorder. So all this. So this is why nowadays how to assess sarcopenia and how to make them stronger or prevent, just like what Elaine earlier mentioned. Okay, for diagnosis or assessment is one side, but how to use this monitoring feedback scheme for training, for treatment or intervention in some way is more important. So if we go down to the level of physiology, okay, what really happens inside muscle. So there's a lot of story we can tell, okay, from the muscle cell, even ion channel change, because as we getting aging, so all this can happen, okay. And through the process, certainly our chemical environment, like hormone change, all this can induce, and particularly for woman, so we all know there's a sudden change at a certain time because of this, okay? So all this can cause in the muscle reduce, fat increase. So we know obesity, and we also know sarcopenia, but actually these two actually can be combined, and obesity plus sarcopenia, so that is, and also the fat accumulation can be surrounding the muscle, but also can be within the muscle. So that is also very similar to other organs like liver. Liver is an internal organ. So outside liver, definitely we can build the fat, but more killing is the fat built into the liver cell. So this is the steatosis. And this is another area we are working on using ultrasound for assessment of liver fibrosis and fatty liver. So that is the idea. So overall, for the sarcopenia assessment, there's a quite established method from very simple tests like a gripping, standing up and then sitting down. So this is timing, and then follow up if there's a suspect case, then we'll follow up with imaging. So I try to monitor time because of. Okay, so then after we confirm with imaging, then more tests will be done. It will be quite severe, and that kind certainly the intervention is needed. So this has been quite well established. However, recently there's more and more evidence, okay, showing that using the traditional imaging method or the quantitative method, the bioimpedance analysis is BIA. So that it does not have imaging, but actually sending some electricity into our body and then calculate the muscle. That is estimate the muscle mass and also the fat, even bone. So all this can be done. And MRI is magnetic resonance imaging, CT is X-ray CT, DEXA is a specific X-ray device originally designed for osteoporosis, okay, the bone loss. But recently they are used more and more for muscle. But all this is a problem because all this not so easy to use. BIA is too rough because you do not know which is muscle loss. This overall body index. Okay, so the accuracy itself is also a question because it depends on many different parameters or environment. So ultrasound recently has been treated as an ideal method, but the challenge is, as earlier mentioned by Elaine, is that we need professionals to operate and to interpret the image. And that definitely will be a barrier for use, okay? Even though CT, MRI definitely even need more higher levels of professional training, but our target for ultrasound is different. We hope that it can be used anywhere, just as Elaine mentioned, the ultrasound can bring to the elderly home for assessment. So this is why with this aim there, all the engineers, all the researchers will want to do is, okay, can we do something to make it easy? So as Elaine mentioned, AI definitely is one, but in addition to AI, we have other like fortunate, okay? I would say is opportunities, okay? Because sometimes if you want to something, if something ready for us to use, and that is really the fortune of the field, okay? So we actually have done a very systematic review, published that is almost the most comprehensive review in the area to understand all the imaging tools, all the assessment tools for sarcopenia, and try to understand which one is more accurate, but ultimately our idea is no one is accurate. Okay, so that is challenging. If we want to say MI is accurate, but if we compare with those people recognize the bioimpedance method, they do not correlate well. So ultimately, our finding in short is very clear. There are two categories of information. One is global body information, like the bioimpedance measurement, DEXA measurement, the overall understanding of our body. Okay, so another area is imaging-based. So that is localized information. So I can know my size, muscle information like a cross-sectional area, thickness, and all the imaging device actually can provide this, CT, MRI, and ultrasound. But they are more localized. And their correlation, the localized correlation with the localized itself, they are well correlated. And the global ones, methods, also well correlated. But these two groups actually do not correlate very well. Now for us, this is actually an opportunity because in the conclusion of this review paper, we mentioned that because they do not correlate, meaning that they have different information. So if we can combine the different information together, we can do a more comprehensive assessment of sarcopenia. So this is our conclusion. But certainly, ultrasound has the beauty of small, radiation-free, cheap, okay, low cost, much more accessible, as Elaine already pointed out for the swallowing assessment. So these are all the correlation, very interesting. Okay, so when we almost spent 2 years to review, okay, the whole field. So I will not go to details, okay? So meanwhile, we are developing this tool we call the Sarcopenia Assessment Kit. And as Elaine mentioned, they are using the commercially available ultrasound for the assessment. So my team in the biomedical engineering department, so mainly focusing on the development, okay, fabrication of new systems with new methods. So this is one of the systems that we developed, a kit, okay? So this is why we have the traditional method, gripping force, assessment tools, and also there's a belt. This belt, when you wear, when the subject were just sitting down and then go up and then sitting down or walking for 10 meters, coming back. So all this will be automatically recorded because we have the sensor inside and have the Bluetooth to communicate with the PC. So the overall idea is with this kit, everything will be quite automatic, okay? And ultimately for the muscle, later on we'll also let you know, we will make it more ready for automation, okay, even the gripping, so we can sending the force into the device. And for some version, we can also just manually input, but overall, we are training a model to see how to accurately assess the sarcopenia with a more reliable index. So you now can see that this is a portable ultrasound, or where later on we'll tell you wearable ultrasound, okay? So the idea is that we just do anywhere, as Yilin just mentioned, but just for different muscles, okay? Not only different application, but different muscles. This is skeletal muscle, Yilin already mentioned for muscle for swallowing. So that is our first paper that we published for the sarcopenia. So try to make it automatic. So the probe putting here, then idea is very similar to Yilin's case. So this, you may realize later on in my other topics, almost the same idea. So we make ultrasound become more specific application. And since it is so small, this is why we can make it the whole device very small, very portable, even wearable. And on the other side, the opportunity coming from AI. Now, without AI, the field will not be so active like now, okay? So this is what we have done. So you can see the accuracy is very high. So we can actually automatically detect or segment the muscle cross-sectional area. So this is a whole system, okay? You can see this is really a kit, okay, because we integrate all this all together. And more advanced version, we can even measure more functional information about muscle during the contraction, how much strength it has. Now, the challenge is for muscle assessment, volume is one thing, cross-sectional area thickness is one thing. But if they do not have strength, the size may not be so useful. So this is why its function itself is important. So to measure function, another way is to measure its stiffness, particularly from relaxed to contract. So you can imagine if a muscle does not have strength, so no matter how you contract, the muscle will not be very hard. But for a very strong muscle, if you just contract it, the stiffness will actually change a lot. So this is why, but some in research, but we'll continuously enhance this system. Even 3D. So because one of our focusing area in ultrasound is 3D ultrasound. So this is why with our probe, this probe actually, this is already commercialized, this probe. This is for the scoliosis assessment, okay, for the back, particularly for kids, okay, for the side bending, okay, of spine. So with that, originally designed for spine, but now we are using this for researching the skeletal muscle for related to sarcopenia, using the overall volume. So this is what we are doing. So you can understand that ultrasound alone for muscle, we actually can get a lot of parameters for different purposes. Okay, so all the above we introduced just to you is muscle static. Okay, but I did mention that we can dynamically measure the muscle. So this is the whole idea, and we even giving the name called a sonomyograph. So this name is a counterpart of electromyograph. You earlier have learned from Elaine and also from Xiaoling. And electromyograph in short EMG. So sonomyograph in short is SMG. So the difference is that electromyograph is to detect the bioelectrical properties or activities of muscle. During the muscle contraction, we have electrical signal generated, so we use electro to collect and amplify and analyze. But for sonomyograph, we use ultrasound. So this term and method actually we invented and pioneered in PolyU 20 years ago. Okay, so we start to work in 2003. At that time, I think around 2004, we create this name, okay, sonomyograph. So the idea is that if you look at the muscle contraction, during the contraction, ultrasound provide the real-time image. But traditionally, sonographer or our ultrasound doctor, they will only look at the image, then use their knowledge to judge whether this muscle has tears, has swelling inside, or any abnormalities inside, okay? So no one has thought about that we can derive a signal. So we are the first group that since ultrasound continuously change. And in the very beginning, we noticed that when the muscle contract, in the ultrasound image, the thickness will change. Remember, in ultrasound imaging, we have real-time imaging. So meaning that 1 second, we can have 30 images. So if I measure thickness, so 1 second, we can measure 30 thickness. Then use thickness, form a signal, then becomes our sonomyographic signal. So this is the very beginning. But later on, we found that ultrasound can see a lot. So information like a fiber orientation, fiber length, even ultimately, right now, we do not actually specifically go into any pattern, any parameter. We're just looking at the pattern. Okay, what does that mean? Even sometimes we do not know. Like later on, we have an application showing you this can be used for control the prosthesis, the artificial arm. Okay, because if somebody lost their arm, so they need to have the artificial arm. But where the control signal comes from? Traditionally, electromyography have been used. Recently, our PolyU actually signed an agreement with BrainCo. I'm not sure any of you noticed this news. BrainCo is a company from Hangzhou, okay? So one of the 6 small dragons in Hangzhou. So their product is to use brain or muscle signal to control many different things. One is prosthesis, other is the brain, the headband for the brain signal, and then to control something. So the overall idea is that they have a system using the electromyograph, multiple, then can control each different fingers, okay? So recently they have shown a very good demo in Hong Kong and landed in Hong Kong. So with this concept, sonomyograph, so in between we have multiple applications and a lot of patents, and try to think how to use this. So the overall idea, we have 2 categories. This is very, very similar to Elaine what I mentioned. One is assessment for skeletal muscle or any other muscle. Later on, we'll share with you the diaphragm for the respiration. And also, that can be used for swallowing or speech or all kind of muscles. Therefore, assessment. But second, once we can have the image, then we can have the visual guidance during the training, no matter what type of trainings, okay? So this one is for walking during the assessment. And Christina is my earlier PhD student. Now she is an assistant professor in our department. So you can see that this is wearable ultrasound now. So in the very beginning, back to 20 years ago, so we have big machine and then a big probe and putting into our leg, and then while walking, the ultrasound need to actually work together, okay? But now as the technology evolves, so you can see that we have put 2 ultrasound probe, one for extensor, one for reflexor, and then continuously monitor this, and we real-time process using AI, all the parameters we are interested. Even my student nowadays, not only the fiber in a straight line, even have a curve. So even use the fiber curve change as a parameter. So basically any parameter can be used for this. Yeah, so this is for the 4 evaluation. So there's a study to understand, okay, whether the frequent faller and non-faller, whether there's any differences, okay, in their muscle reactions. So again, all this using the ultrasound to monitor and automatically detect all these regions, particular thickness. And this is the first paper we published non-medical. So this student a few years ago that we thought, okay, if we can use for training for stroke survivors during rehabilitation, we can equally use this for other purposes. And one is for fitness. So at that time, we just imagine if somebody want to train their chest muscle, if we give the guidance, this is your target. Okay, this is your target. Then whether that can be better or not, say, okay. So our result tells both a short term, immediately, and also for during some period, whether the muscle can really get strength or not, both actually increase with the image guiding. So basically, this is the exact concept, no matter for swallowing related muscle assessment or training or other muscle training, with the image guiding, definitely has a better performance. So I think in the next slide, I should have the stroke. This is for sports. Sports is another area. So I think in this series of class, our department of biomedical engineering, Professor Ming John, and my successor, because before that, I'm the founding head for biomedical engineering. So this is why we have two research institute actually associated with us, and another one is research for sports. So during sports training, you can see that ultrasound has been used as well. So this is all the muscle training topics. And this one is for stroke survivor training. Again, we already published this paper and demonstrating that with the visual guidance, better performance can be achieved. Okay, so this already be quantified and with evidence. But certainly, we are thinking how to make all this training, including Elaine's training, much easier and much more accessible. So as I mentioned, there's two things important in our field to make all this product become possible. One is AI, because we just set target and train the model, and with model, the model can do all the analysis and interpretation. Another one is how to make ultrasound smaller and smaller. Certainly, this may not be totally our efforts, because the industry is growing. Okay, the industry. So this is why I just want to show you how small the ultrasound module that we are using now. Okay, at this moment, this is the whole ultrasound module. You can even never believe that the image is same as those big machine. Okay, in the hospital. So what it contains? It contains all the electronics, battery, and even have a wireless charging coil here, and has Wi-Fi. So meaning that the image can real time send to, now actually if this is my classroom, I will set up here and immediately will let you see that my muscle moving, and here you can see. Okay, so these are all the state-of-the-art technologies right now. So I believe, because we have the needs, with like 5 or 4 years later, maybe only half of this size. The reason, because we need to put on the body while walking, running. Already, somebody already putting this kind of device, at that time still quite large. Okay, a few years ago we noted, during the marathon, like a standard child marathon, very strong. So they will actually monitor the muscle throughout the whole process. So that is really meaningful for many areas. So this is, for us, just one. So I always put this in my pocket. Okay, so I need to leave some time for brain. Okay, so now we go to brain. In some way, brain is more important, right? Without muscle, we still have many ways to do, okay, and to even to think, okay? But without brain, or brain is malfunction, then we have big trouble, okay? So this is why how to make our brain healthy is really the first target, okay? Even though any part of our body is important. So mainly we have 3 areas of focusing. I will cover 2 because we have done most in these 2 areas. One is for stroke, okay? I always joke with Xiaoling, because my colleague, Professor Hu Xiaoling, because before we move the lab, our 2 labs is in neighbor, okay? So outside is my lab using ultrasound, and that time we started working on stroke, okay? Our purpose is for early diagnosis, the risk assessment. So we hope that we can find some risk factors and to save some, okay? Not going into that. But inside is Xiaoling's lab, and it always has stroke survivors passing through our lab and go into their lab for training because they are stroke survivors. So this is why I always actually share with our two teams, okay? If we can stop, not half, okay? 10 or 20% of cases leading to stroke, actually we save a lot, okay? Because we all know, okay, once have a stroke case in a family, a really big burden, not only to the subject, to the survivor, the whole society, community. So this is why any possibility, if we even tiny, we'll try to save. So for ultrasound, again, has been commonly used for the carotid artery assessment for the plaque. So this is very common. And for brain, has been used for many years, and mainly focusing on re-stroke, meaning that if somebody after stroke inside the hospital, and they are worried about the plaque will go to brain to block again. So this is why there's a device called the TCD, transcranial ultrasound Doppler, and that can continuously monitor the blood flow. So if some part of the blood being blocked, then the flow will instantly increase. The reason is very obvious because our brain is functioning. So if the volume, not volume, the diameter is smaller, but the brain still needs this volume of blood to let our brain to run its function. So therefore, the blood flow will increase. So this actually be an indication of the block, okay? Not totally blocked, okay? Once totally blocked, there's no blood flow. So this has been used commonly. But with technology evolves, we can not only measure the blood flow, but also can image the brain. Okay, so and the resolution is higher and higher, cost lower and lower, size smaller and smaller. So with all this, we can do more in the stroke to understand the blood vessel. Okay, and second is Parkinson's disease. The PD, PD because there's some damage inside our midbrain. Okay, that specific area called substantia nigra. Okay, substantia nigra is an area that releases dopamine. So if that area being gradually damaged, so our hand will be like this, okay? There's a very typical symptom of Parkinson's disease. Certainly there's a lot of other symptoms. So the last one actually is, in general, we call it Alzheimer's disease, or commonly we call it dementia. So similar, that is a brain functional damage, okay? So there are many ways that using ultrasound to detect, but many are still on very early research, is why I will not go into details. I will go to these two first, okay? For Parkinson's disease, there are many ways, okay? And the most accurate way certainly is the nuclear medicine, okay? So we call it PET. And MRI, the functional MRI can also do this. I will not go to the details. Yeah, the CT with some contrast agent, people are also starting, but mainly is the nuclear medicine-based imaging and also functional MRI. But certainly we all know this is big, okay? We cannot do the routine screening or reassessment very frequently. It's almost impossible. So for ultrasound, very fortunately, so again, very fortunate because ultrasound can see that location, and when it changes, the pattern, the echoes from that location will change. So that is why we can use ultrasound. You can actually see that later on I have a video showing how the image being obtained. So that region, in the healthy situation, everything is clear or dark, okay? So if basically some metal building, okay, in that substrate region, in MRI, it's very, very clear, okay, so we can see that, but in ultrasound, we can also see that, okay, so this is the idea. Now, you can see that the sonographer will hold this probe, actually rotate, because this is inside deep regions, okay, of the brain. So we only have a window called a temporal window. That part is, the bone is relatively thin and also tight, not so many pores. But other regions not so tight and have a lot of porous inside. So this is why ultrasound cannot pass in well. Even we reduce ultrasound frequency, still cannot pass. So again, this is fortunate. Without this window, ultrasound cannot pass. And many stories I'm telling you today is not possible. So this is some kind of coincidence, okay? So leaving these two areas, so you can see the fan-shaped ultrasound beam going into the brain, and then we can, because the window is very small, this probe we call the phase array, very similar to the array used for heart. Why heart also need a phase array? Because we need to see through the rib. So this is why the aperture or the window is limited. So the only thing we can do is that the aperture itself is small, but have a fan shape, so reaching a larger area. So this is how brain and heart need this technique. So these are all different images, okay, so we can get. The first thing is that this kind of assessment using the BMO ultrasound, we call the transcranial ultrasound, need very sophisticated sonographer. Even nowadays, only very few hospitals, okay, they are providing this kind of service. Not all. So this is why our goal is to make this easier to understand, easier to get. So the first thing is that where the target is. So using the AI will real time tell you which way you go, okay? And once you get this target, so we'll let you know. So I think that there's I should have a video later. Okay, so this is what we can do for the segmentation. So this is why the doctor or the sonographer do not need, okay, to do by themselves for the assessment, because ultimately they need to calculate how much has been occupied by those abnormal structures. So the left side is what doctor normally see, okay? So almost to us is just like a blinded, okay? But for doctors, they have got years of training, years of practice. So this is why where they should go, when they should capture the image for measurement. So certainly only a very sophisticated doctor can do this. So, but with our automatic detection and classification, so we will guide them, oh, here is where you are, and then you can start to capture the image, or we can automatically capture the image, then you select, okay? So this is the automatic guiding. And this concept we are using now in many devices, including the commercial available device we call the liver scan. So for the liver assessment, previously also professional only professional can do this, because for ordinary people even do not know what in ultrasound the liver looks like. But now with training, we have used the 10,000s of images to train what is the liver, how the liver looks like, the image. So we'll automatically label the liver for the user. So if you see the liver is not large enough, you move a little bit to that side, so liver become larger, and then it will indicate, now is the time for you to conduct measurement. So this is the idea. So similar. So once we have the image, then we do analysis, segmentation analysis, ultimately is to decide, okay, whether there's a risk or not for Parkinson's disease, even for staging. But certainly in medical field will never based on a single modality, right? So as long as you have all the information available, we can combine all this information together, no matter clinical information or other imaging information. So this is what we are doing for this multimodal, we call the classification or diagnosis. So here is a segmentation. Okay, now let's move to the stroke. Now, the idea is very similar, but this time we're more focusing on the vessels, or more specifically, artery, because the brain, inside the brain, actually, there's a main, we call the structure called a circle of Willis. That is the main structure. And for those of you working in the medical field, you definitely know, again, our body or even our brain is designed so elegantly, okay? So the circle of Willis is really redundant like a design, okay? So normally our vessel is just a artery, then vein. In between is capillary, right? So, but for circuit wireless, all the artery, okay, supplying the blood to the brain, they all link together. So why? If one branch blocked, the blood can come from other branch. So this is really, really clever idea. So, but certainly everybody's circuit wireless is different, okay? So this is the idea. So again, for stroke risk assessment, using MRI, CT, or PET is almost impossible for screening. Okay, many people, fortunately, while they do some assessment, like take an MRI for other purposes, and they found their blood vessel is very narrow. Okay, so there are many, many cases like this. But since it's too expensive and too inconvenient to go to do screening, okay, using MRI. So this is why ultrasound poses a very unique role, okay, in this area as time going. Okay, so what we have done in our lab, so you can see, again, certainly all these are going to the aging people, elderly people. So we have scanned around 300 elderly people with MRI, and simultaneously we conduct ultrasound. So for this study, we use the rotation of the probe so that we can have a 3D ultrasound images. So actually you can see the circuit wireless in right side, that image, red block is the circuit wireless. Under the MRI, we call it MRI angiograph or MRA, okay? So because that is specifically, the sequence is for the vessel, okay? And the left side is the 3D formation that we obtain using ultrasound. Okay, let's see again. So the left side is the original image. This time the color, we call the color Doppler. So that is based on Doppler effects. The idea is that inside this color region, there's these vessels. Inside vessel, we have red blood cells. So once a red blood cell moves, it will modulate the ultrasound signal. The frequency will be changed. Okay, so no matter it is facing the beam or leaving the beam, the frequency will change, either increase or decrease. And this can be detected by our device and then form this kind of color. So this is why there are two colors, and one color is the blood leaving the transducer, and the other color is towards the transducer. So this is very common, okay, in ultrasound, already be there for several decades. But right side is new, okay? So while we are rotating, we train a model so that we use different colors this time to indicate which vessel, because the circuit wireless is multiple vessels. So we can automatically identify and tell the doctor which vessel you are now scanning, and with this, certainly we can accumulate all this information to form 3D. And these are all different kind of subjects, and we can see. So you can see for some subjects, we can see better about the structure, some not. Do you know why? That's individual dependent. Like myself, again, a coincidence. Among my team, I'm almost the best quality of image. I don't know why. Maybe this is designed for B2 working in this area. Okay, so this way I can see the whole structure very clearly. But actually, according to our published research in Hong Kong, around 85% of elderly people have this temporal window allow ultrasound to pass, either two side or one side. But still have around 25% of elderly people will not allow us to let ultrasound passing through. Okay, at least for the frequency that we used. But technology is evolving very fast. What we use is around 2.5 megahertz. I just tell you for muscle, what we use is 7.2 megahertz, 7.5 megahertz for all this muscle. And for brain, what we use is 2.5 megahertz. Normally for abdomen, so this region, we'll use 3.5 megahertz. And for eye, like a cornea, we'll use 50 megahertz to understand the cornea. So this is why, because a higher frequency can have high resolution, but it's shallower the penetration. So this is ultrasound. So we cannot have both, okay? We only have one. But certainly, technology evolving. Recently, I discussed with a company, their product using 1 megahertz transducer for the brain. And their image is wonderful, almost like a CT. So this is why still a lot of innovation waiting for us to go to develop. This really imaging that we can get. Yeah, so we compare and also publish the paper. Let me see. Yeah, finally, this tool is very, very inspiring. For those of you earlier, you are getting sleep. It's totally fine. But for this slide, I will suggest you pay attention, okay? Because this is the future, and maybe a Nobel Prize, okay? Because this has been here for around 15 years, okay? In research field, still in research, okay? Not a lot of applications. But I just want to share with you. Can we click the left side? There's two images. There's 2 videos, yeah. Because this is two formed by my student. We are working in this area. But this one 3D is animal, the rat brain, okay, and the skull removed. So this is why we just want to see all the details with ultrasound. But this ultrasound is very special. We call it super resolution ultrasound imaging. But why call it super resolution? Because for any imaging, the resolution limit is half of the wavelength. For those of you in the engineering field don't know that. In the health field, probably your physics are not so good. So this is why you may not know well. Basically, if any wave, okay, so like this, doing the wave. So always have the peak to peak. That is the wavelength. Okay, so that wavelength limit the resolution. So for optical imaging, no matter how high frequency of optical image, normally these days we all know the purple light, because using for the chip making, okay, so they need a purple light to exposure, because as the wavelengths, okay, or the color go to the purple side, the wavelengths become shorter and shorter. Okay, so only with that we can have a nanometer like a scale for this. But anyhow, similar for ultrasound, so it is limited by wavelengths. But how we can achieve this kind of imaging? This is very special because we inject the contrast agent. Now, any imaging has a contrast agent. Because of time, I have not discussed that. For MRI have MRI, X-ray has X-ray, and CT. Okay, so ultrasound, the contrast agent is microbubble. So we inject some microbubble into our body and then circulate. So the bubble will go through all these vessels and then give all these images. So this is formed by bubble. So right side is not our team, but published, okay? So this is the very first paper that showing using the ultrasound for the human brain and get this kind of image with resolution much better than MRI, much better than CT, and see all the vessels. And so this is for diagnosis purposes and for research purposes. This field is going on there. So you can see, can I play the right side again? Yeah. And also the top one, yeah, top one. Okay, so the idea you can see that I put an the ultrasound transducer here through the temporal window, as I mentioned. So the top and the bottom actually is separated. So for the top, you can see this is what normally we see, the ultrasound image. And then with the bubble injected, the ultrasound actually will be, yeah, suddenly bright. So this is a contrast agent effects. But with that, the only thing we can see a little bit better, but we cannot see any vessel. So the red dot is identify the microbubble. So the bubble going through the circulation, and ultimately we can draw all the vessels. So this is why I always say to that team, one day if this can be widely used, they can know the Nobel Prize. Because without this method, we cannot, okay? So I think I almost used my time. So let me quickly go through this. So as I already mentioned, okay, we need two. One is AI. AI is rapidly increase, and ultrasound is rapidly decrease for the size and cost. So with these two put together, the remaining thing is idea, okay? All the innovative ideas. So this is why we have these opportunities. So this I think is my last slide. Okay, one for the left side is what I mentioned for the sclerosis using 3D ultrasound, and right side is using a very tiny ultrasound device and putting into market. Both have got FDA approval and China approval, and Hong Kong both have been installed for different. So with these two put together, there's tons of opportunity. So what we realize is only two. Okay, so as the first time we mentioned that in PolyU we have these two wonderful platforms. One called the Research Institute for Smart Aging under the pair, and second is a Jockey Club Smart Aging Hub, and to provide the service and applications. So I would like to stop here. Hopefully, you have patience to take some question. If not, you urgently, now you can leave. Okay, thank you so much. Yeah. Answer? Okay, so, and really, if you have a question and you are not interested or something to do, not the wife or husband are waiting for you, please.
Online, yeah.
Yeah, I just select a few questions if I can, okay? SMG can detect muscle fibrosis or adhesion. This is a great question, okay? So for fibrosis, we normally use elasticity measurement, and definitely that signal itself, how strong signal, it's also reflect the muscle stiffness. So in some way, it's also related. Adhesion, I think definitely we can, okay? And similar, we can use elasticity imaging. And I have the same question, okay, as earlier mentioned. Sorry, it should be, I have the same, okay, it's okay. About PD, what is the image by ultrasound? Oh, that is a substantial negra B-mode ultrasound. So this is why we are also working on Doppler as well, super resolution as well, but that will be in the future. Yeah, that mainly is telling us whether there's a metal accumulation for PD in that area. I prefer test to. Okay, that is a specific question. I think I can skip this. And percentage change of volume or color in midbrain substantial negra is positive or okay. So for that specific diagnosis, if there's a echogenicity, meaning the bright region increases, that means that PD severity is higher. So if totally clear, meaning totally dark, it is safe. It is more healthy. Can use over the brain can detect small or mild microbleeding. Yes, I think for detecting microbleeding inside the brain, this field is quickly growing. I do believe with the super resolution that can be solved. From your presentation, you guys can diagnose PD. Yeah, the answer is yes. Okay, so ultrasound can diagnose PD. However, for any imaging modality, always have limitations. So this is why we cannot say 100%, okay, even any imaging modalities. So this is a point just want to make. So thank you so much for staying here. This is the last question. So if you have any questions, certainly if you want, you can ask, okay? Thank you so much for patience, and we are very sorry for overrun. And for those still online, again, yeah, we want to say goodbye. Have a nice weekend, all. Bye-bye.